We are very excited to welcome you to this first episode of the Lupus Academy podcast, which we hope will be the first of many. I'm your host, Raquel Faria, a doctor in internal medicine at the Centro Hospitalar Universitário de Porto. In these podcasts, I will talk with experts from the Lupus Academy Steering Committee about the highlights of this year's congresses. We will discuss difficult cases, and we will also have an episode where we review all the exciting things that have been happening in lupus this year. You can listen to this podcast on Spotify, Apple Podcast, or wherever you listen to podcasts. All episodes will also be available in the library of our website. Please check the show notes for all relevant links. The Lupus Academy has been providing accredited education for healthcare professionals since 2012. And with this podcast, we plan to provide you with regular updates in the field of lupus, which we hope you will enjoy wherever you're listening. And with this, we move on with the first episode in which we will discuss the lupus highlights presented at EULAR 2022. I'm pleased to introduce the experts of today's episode. Welcome Professors David Isenberg from UCL in London and Ronald von Vollenhoven from Amsterdam University Medical Centers. Both have been members of the Lupus Academy Steering Committee for over 10 years. I am sure that their experience and expertise in the management of lupus will charge this podcast with insightful discussion and help us better understand what new research in lupus means for clinical practice. Welcome, gentlemen, and thank you so much for doing this podcast with me.
Thank you.
Thank you, Raquel.
After EULAR and the data that was presented in EULAR on lupus, what do you think are the most striking research that could stood out for the patients, the researchers? What do you think? Do you have any thoughts? David.
Okay, so thank you, Raquel. So for me, the biggest dichotomy really of my career is that on a Friday afternoon, I do a general clinic and I see patients with rheumatoid, psoriatic arthritis, ankylosing spondylitis. And I know that even if conventional drugs work, proved ways to go in terms of biologic drugs or small molecules. And yet I go to the same room on a Monday morning, I see lupus patients and I know that I can use Benlysta in a very restricted number of patients, rituximab slightly more widely, and that's it. There's nothing else available. So for me, what was great about EULAR this year was that there do seem to be some real significant breakthroughs coming through. We all know that anifrolumab and voclosporin have been improved, so there was some more data coming out about those two drugs. There was some interesting data about, now the pronunciation is the biggest challenge, deucravacitinib, if I get it right, looked very interesting. It's an oral selective inhibitor of tyrosine kinase 2. That looked quite interesting. There's another brutinib, oral brutinib, which is coming through. That looks quite interesting too. Less encouraging, unfortunately, was the data with baricitinib. That wasn't so good, but at least for me, it was actually very encouraging that we've got some potential exciting drugs, perhaps not too far away.
I know that you completely agree, Ron, but do you have any other thoughts to add on?
Well, I would like to start confirming that the excitement in the world of lupus is really very tangible. And the excitement is in large part because of the fact that we are now seeing new therapies emerging. But that doesn't just happen on its own. And I think it's important to realize that if we are now seeing a number of very promising looking therapies emerging, it's because we have gained a lot of understanding how lupus comes about, what are the processes that are taking place in the patient, why is the immune system responding in this way? And we have discovered that there are very many different mechanisms, and they may be different mechanisms in different individual patients. But for each of these mechanisms, there is a compatible therapeutic intervention, and those are now coming to the fore. That's part of why we are excited about new developments. The other thing that's also exciting is that we are getting better, slowly but surely, I emphasize also slowly, in doing the clinical trials. And I think, Raquel, David, you both know this. Many trials in the past have not been successful. And now it's always hard to know if that's because the drug wasn't as good as we thought, or was something wrong with the way the trial was done. But be that as it may, in recent years, we've now seen a number of successful clinical trials, and it, I think, pays tribute to the success of the drug, but also to our ability, the ability of many who have worked with clinical trials to set it up in the correct way, to analyze it in the right way, to find the good outcomes, and then by doing it that way, to be able to tease out the true efficacy of the drug.
Perfect. So you both spoke about two new drugs, and Ron, you highlighted this thing that huge clinical trials have failed in lupus. Some of them, we don't know if the molecules were going to do anything or not. But for the others that, like voclosporin, have been presented for the past few years with some good results, and it was also presented. What is your thought about, are we going to get it? How long are we going to get it for? And what do you think about the use with these new data of voclosporin in lupus nephritis?
So there's another very important point which we should talk about, and that's the cost of these things. Because I often think when you're thinking about new drugs, there's a sort of holy trinity effect here. You have to show that your drug is effective. You have to show that the side effect profile is satisfactory, and that it is at a cost that your country can afford. And I know it won't be the same in other parts of the world, but the story, as I understand it, in the United States, is it costs $92,000 per patient per year. And that's an awful lot of money. And there's no way that in the UK, for example, that NICE will ever approve that. So there's no chance that in the UK we will ever have voclosporin unless the price comes down substantially. And the same is true, incidentally, of anifrolumab, which is $46,000 per patient per year in the States. I mean, hugely expensive drugs. So although I think the something with voclosporin is encouraging, there was an initial blip when in the phase 2 there were 11 deaths were recorded, which was rather concerning, and we might want to touch base on why that happened. But certainly in phase 3 there were none, and subsequently it seems to be a pretty safe drug, pretty effective drug. I mean, the data actually I thought were quite compelling. But obviously it's of use in lupus nephritis. You're not going to use it really in other forms of lupus. So I think such data as we have in terms of its effectiveness, its subsequent side effect profile are fine, but it worries me about the cost. That is a concern.
And do you think that the cost would be? Yes, Ron.
I completely agree that cost is a major issue with new therapeutics, and I think all different countries and paying systems deal with it in different ways. I know, David, that you have a very tough system. Some countries have it a little bit easier, but we all have to think about both the patient and about our societal responsibilities. But as to voclosporin specifically, it is, of course, very limited in terms of having to offer something for patients with lupus nephritis. That could be very beneficial. We have obviously used in the past cyclosporin, but with the concern that it would cause long-term decreased renal function, hypertension, and on account of those properties, it has not been very widely used. Maybe it will be a little bit different for voclosporin. I do not have any personal experiences with it. I did not participate in the trial, so I'm still waiting also to learn about this myself.
So just to pick up on that, Ron, so as you know, the system in the UK revolves around the National Institute of Clinical Excellence, or NICE, or sometimes not so nice as we think of it. So they are very effective, though, you have to say, in terms of forcing the companies to reduce prices. So the cost of Benlysta was forced down from about $30,000 per patient per year in the States to approximately a third of that in the UK. And so from, as you say, from the societal aspect, I mean, it has provided a very useful benefit. The cost is now at a level which the UK deems that it can support. The problem that we've got, and I don't know whether it occurs or how much it occurs in Central Europe, is that we still have very considerable restrictions around the use of Benlysta. So we can use it for patients who've got skin and joint disease only. They had to have a sleep score above 10 points. But to get that, if you've only allowed skin and joint disease, you've more or less got to have both high DNA and the low C3, otherwise it's very hard to get there. So the consequence is that in the UK, since 2016, when Benlysta was approved in my own unit, I've only been able to treat approximately 25 patients. And at the same time, out of interest, I've treated probably 100 patients with rituximab. It's really quite a striking difference.
Ron, you have a more broad use of Benlysta in your clinical practice than with MICE's restrictions.
So I think in the Netherlands, the payers have worked together with physicians, with patient groups, and other stakeholders to try to come up with a reasonable and equitable way of using drugs like Benlysta, which is, of course, belimumab, an expensive biological, but not very different from other biologicals. I think that we do have a reasonably good situation in the patient where it's medically appropriate to use a drug, we can use it. Now, then you say, okay, so how much use is there? And I think that the use is actually still somewhat limited because rheumatologists are, believe it or not, a bit conservative in their way of approaching patients. And I think that differs also by country, by culture. I don't know if you know that I used to work in the United States this many years ago. I think physicians in the United States have a somewhat different attitude. If they know that there's a new treatment, they want to try use it immediately. Whereas I sense with my colleagues in the Netherlands, and I found this in Sweden as well, that many of my colleagues would say that, well, let's just wait and see a little bit how it goes and try to maybe get a little bit more of a feel for what is necessary. So there are these cultural differences. I think the use of new drugs is always a little bit of a balance because, of course, you never know for sure. We get data from clinical trials, they're aggregate data, big groups of patients. But how will it work at the individual level? It's almost impossible to know. And as a physician with practice, we get a little bit more of a feel for which patient is the right patient for the drug and the right drug for that patient. So I think there's a slower learning phase. Of course, the manufacturers of the drug don't like to think of it that way. What they hope for is a big, quick uptake because they are also limited in terms of the time during which they can sell a drug, if you look at the macroscopic level. But we need to get that personal experience. I do think that it would behoove the regulators to allow physicians more in the way of gaining expertise. That would benefit the patients in the end, that would benefit the medical profession, that would benefit very many stakeholders if there was a little bit more room to try things, find out for yourself how it works. So I'm always trying to advocate for that.
Yeah, the phrase, I absolutely agree with that. The phrase in the UK is better the devil you know than the one that you don't know. And so people get to be very conservative. But there are immense frustrations here. Ed Vitale at EULAR showed a very interesting poster in which I think he had about 7 patients with very nasty, very aggressive, active lupus affecting the skin. And he reported that these patients had been on conventional drugs, steroids, methotrexate, etc., hadn't helped the patient. They'd been on Benlysta, hadn't helped the patient. They were given anifrolumab, and the results were spectacular, and he showed the pictures. And yet the fact is that AstraZeneca have already said they will not take anifrolumab to NICE because they're worried that the NICE will drop the price very substantially, which they undoubtedly will do, and therefore it will become financially not worth their while. And so again, we won't get voclosporin. We can't use anifrolumab. The company said they're going to try to set up a sort of compassionate use process, but it doesn't seem to have got off the ground yet. And it's very frustrating knowing I'm sure you two have got several patients who I'd love to give it to, but I can't.
Well, I didn't even realize that was the case, that anifrolumab will not be submitted for regulatory review or for payer review by NICE. Sure. We, of course, are now anticipating that we will be able to start treating our first patients with anifrolumab very soon in the clinic in Amsterdam. And so I think when we talked, Raquel, you had asked about excitement.
Yes, and
I think there was excitement. Yes, and there was excitement about voclosporin as a new treatment for nephritis, about belimumab, which has already stood the test of time and now also is approved for nephritis. But I do have to say that the most excitement does probably revolve around interferon antagonism as a therapeutic principle, and having a drug that is now approved at least by the EMA, it is approved, and then the payers will have to say what they want to say. And that is a new therapeutic principle, and with some definite promise, also some big questions still. And one of the promise, of course, with the skin disease, the results are sometimes reported as quite outstanding. But also for other organ systems, we are really very, very interested to know how this is going to play out in the clinic.
I'd like to ask your opinion about something that is worrying me with the introduction of anifrolumab. We don't have that special patient that fits anifrolumab as we didn't have when belimumab started. And belimumab is now more than 10 years in the market with availability to use it. And the right patient that we know that will respond, we don't know it yet. So sometimes I'm afraid that we're going to have the same thing with anifrolumab, even though we are expecting that it will do huge things. But in the practice, if people start using it when available and it doesn't work, as you said, Ron, we need to have personal experience and center experience. And I'm a little bit worried that if we don't find the right patients to give at first, we're going to delay a little bit the right patients to have the treatment. I don't know if I made myself clear with the opinion I'm asking you on this. What would you think that we can try to think on which are the anifrolumab patients, and are they coinciding with belimumab patients? What do you think about it? Ron, can you go?
I have a couple of answers to that question. I have a couple of thoughts because I think it's very fascinating, but my answers some of them are going to be controversial. So the easiest answer is you are right and we don't know, but that's not a very nice answer. So the second answer is, well, there is a lot of those who have been participating in the trials with anifrolumab or with other interferon antagonists that say that especially the skin disease is really very responsive and it also happens quickly. So that may be a logical first selection of patients that you would like to try this new treatment on once it's available for you in practice. But my third answer is the more controversial one because there is the interferon signature. And as we now know, about half the patients with lupus, when you test them in the lab, have an interferon signature. And everywhere in Europe, clinical labs are now beginning to offer the interferon signature. So to me, it makes perfect sense that you should get the interferon signature as a test to see if the patient would be likely to benefit from an interferon antagonist. But this is controversial because the EMA and also the FDA in the United States have not taken that position. Remember, in the approval, it says nothing about the interferon signature. And AstraZeneca, the company that makes the anifrolumab, points out that in the clinical trial, it wasn't clear that patients who had no interferon signature did not respond to the treatment. But my answer to that is that it was also not clear that they did respond. So I think, you have to sort of use logic a little bit. And if the patient doesn't have interferon activation, why would you block it? But like I said, I'm sticking out my neck because I know a lot of people disagree with me. Ed Vittel, your colleague from the UK, David, had published these data not too long ago in the Annals of Rheumatic Diseases, where the curves that show the response very nicely diverge for the interferon positive patients, but they do not for the interferon signature negative patients. And I would have liked to see that those who are developing this drug would have embraced the position that there is a biomarker for this treatment, because having a biomarker for a treatment is a great thing. And it's only a first step, of course, but we have to start somewhere. So this is my answer, and others can start shooting at it.
And we can add some controversy to that once post-hoc analysis of Benlysta also showed that people would respond with high interference. So thoughts about the previous and now, David?
So I think the thing about anifrolumab is that we still don't know an awful lot about its effectiveness in situations other than skin disease joint disease. We need to get more data about kidney disease, about lung disease, about heart disease. So I think, as I say, the jury is still out here. But I accept what Ron is saying, because there is a certain fuzziness around these things. And we also saw that, for example, with rituximab, where when rituximab was brought in by my former colleague Joe Edwards for the treatment of rheumatoid arthritis, everybody assumed that if you didn't have rheumatoid factor, it wouldn't work, because after all, it was going after the B cells. But actually, I've seen this, not a large number, but I've certainly seen a small number of patients who are rheumatoid factor and anti-CCP negative, and yet they still seem to respond to rituximab. So I think that we must allow a certain fuzziness around the edge, and it may well be that, as Ron quite rightly says, look, we're all looking for precision medicine. We're looking to try to find, as you say, Raquel, match the patient with the drug. That's what we want to do, and it makes sense that if your interferon message is high, you're more likely to be a responder. But it doesn't prove that if you're not high in terms of your interferon message, that you absolutely won't respond. So at some point, you may have to try it and see. But by and large, obviously, we need the biomarkers to guide us. Because at the moment, as you know, we've got this very tricky problem with our rheumatoid patients, and I feel this very badly. That I know when a patient goes onto a biologic drug, we've got, as I said before, about 5 different ways to go. But I haven't got a clue with the patient sat in front of me whether they're going to respond to tocilizumab better than abatacept, better than baricitinib. I have no idea, and it's all done by trial and error. It's expensive. It's a waste of time. It's a waste of the patient's time and the country's money. We need much better biomarkers, much better cues as to which patient for which drug for which patient.
Can I launch another challenge for you to discuss? Yeah. We are talking about trials. You both have huge experience helping to design them, analyzing them. What do you think is needed to do to the placebo group so the difference would be? How would you give advice to a company that wants to do a clinical trial in lupus so it can be really proved if it works or not, and leaving us not without no doubts, but with little doubts about it?
Well, I think there's some very important issues here, Raquel, as you obviously know. One is the huge disappointment that we've seen with ustekinumab. We've seen before that with eprotuzumab, drugs which seem to work in phase 2 and then are duds in phase 3. It's so disappointing. I mean, that's happened to at least 4 drugs that I can think of. And I've looked recently with Maria Delera and a colleague of yours from Portugal, Dr. Frua, and we looked in great detail at these 4 drugs, trying to work out if there were any clues as to what was going on. In the main, the phase 2 drugs tend to be smaller numbers. They tend to be for shorter periods of time. That's part of it. And there are important issues around the placebo. Certainly in lupus trials, a placebo response seems to be in almost every trial which does work, about 35 to 40%. When a trial's like with the aprocizumab phase 2, it was about 20%. That alarm bell should have rung at that stage that there was something wrong with that trial. And I think it's strange, isn't it, that we get these very high placebo responses. But of course, in one sense, of course, it's not strictly speaking placebo versus the test drug. It's always lots of background meds plus placebo versus lots of background meds plus the real drug. And people sometimes forget that. And I think if you want to give a drug a chance to shine, let's put it like that, you need to keep the steroids as low as possible. If you can, the other immunosuppressives as low as possible. That at least gives your drug a chance to show what it can do. Without that, it's difficult. And I think the great success for me of voclosporin, beyond the fact that it worked, was the fact that they demonstrated that you could cut the steroids down to 2.5 after 12 weeks, which certainly colleagues of mine in the States said, oh, it's impossible, you can't do that. Well, they did it. It was possible, and it showed that voclosporin works.
Ron, do you have anything to
I'd like to say, yes, thank you, Raquel. I would like to say a few things about clinical trials. The first is that we should not complain too much. There is a little bit of a tendency in the lupus community to say, it's been so terribly difficult with the clinical trials. We've had so many failed trials, but we are is sometimes feeling a little bit too sorry for ourselves, because in every medical area, there are trials that fail. An executive from a pharmaceutical company will tell you that of all the drugs that are tested in phase 1, only 1% makes it to phase 3, and they fall down by the wayside in big numbers. So of course, yes, there have been failed trials in lupus, but I'm not convinced that they are disproportionately more failed trials than in other disease areas. Having said that, it's also clear that the trial poses a particular challenge in lupus because of the way that the disease is. It's a very capricious disease. It goes up and down. It doesn't allow itself to be predicted very well. So when a patient comes into the trial, if you would have to guess what's going to happen, you actually are probably going to be wrong many of the times. And so I think that it's not crazy to think that doing the trial is harder in lupus than in other areas on account of the complexity of the disease and the outcomes. But like David, you were just saying, we have gotten a lot better. We figured out ways to minimize exposure to other treatments. We have worked on the outcomes. Actually, I think you and your colleagues in the British Isles with the BICLA have actually deserved a lot of credit, because that outcome saved anifrolumab from regulatory demise. Because the SRI-4 failed in the first of the 2 phase 3 trials. Still hard to explain, because it did succeed in the second of those trials with both the BICLA and the SRI-4. Yeah. So I think we don't understand everything, but we've gotten many more tools now in our toolkit to do a good clinical trial. And that's, I think, why in the last year, we've seen a whole slew of clinical trials succeeding. We've already mentioned anifrolumab. We mentioned nephritis trials with belimumab and with voclosporin. But we haven't mentioned yet a number of agents that were successful, such as litifilimab, that's the old BIBO59, deucravacitinib, which you also struggle to pronounce, David, and so do I. And there's been several others that were successful. So it's actually going very well for lupus trials in 2022, and that's exciting.
But I think, Ron, there's another very serious point which we also should just touch on, and that is, well, the two aspects of this really. As you said, lupus is a very challenging disease. It's not like rheumatoid, where you're just looking at one organ or system, and you've got an ACR 20 or 50, 70, whatever you're using. It's relatively straightforward. In lupus, on the one hand, you've got lupus nephritis. Every company does 2 kinds of trials. They do nephritis trials and non-nephritis trials. And nephritis are easy in the sense that you've got a nice hard endpoint. You've got a biopsy, you've got a serum creatinine, a protein creatinine ratio. That's relatively easy. The challenge comes with the non-renal patients. And here you really do need to get into your clinical trial centers who know what they're doing, with physicians, hopefully, who know what they're doing. And just a little anecdote, I was involved in setting up the original atacicept trial, which was a flare prevention study trial. And I was asked by the company to teach the use of the biolog, which is what they were using, to all the different centers. So it was a lot of traveling in the old days before Zoom, pre-Zoom. And what I discovered, because I set an exam, so I would teach them, they would listen to a little video, they'd be shown some cases, then they got an exam. And the real emphasis was to try to get over the point, a very important point, that lupus patients have lots and lots of symptoms, but they're not all due to activity of the disease. They could be due to damage, they could be due to concomitant disease. And I'll give you a little example. So there was one case history which I gave as part of this exam, in which I said, patient develops severe fatigue. Patient's thyroid tests are done. Turns out to be hypothyroid. Patient is given thyroxine. Patient gets better. Question, is the fatigue due to lupus? And you'd be amazed, 30% of respondents in that exam said, oh yeah, fatigue, that's a lupus feature. So yes, it's due to lupus. But it wasn't. It was due to the hypothyroidism. And that's how mistakes get made. And the other big thing, for example, with the SLE system, which you know very well, is the lupus headache. The biggest problem of the lot, really. Gets you 8 points. But how often do you really see a lupus headache? I mean, I can't remember the last time I saw a patient whom I was convinced that the headache was purely due to the lupus. And yet in some of these clinical trials, I've seen quite a lot of the data. I always suspect centers where, let's say 20% of their patients are getting into the trial because they've got lupus headaches. I've seen that. It's amazing. So you have to choose, the companies have to choose centers very carefully. They need monitors to be really quite pushy in terms of, why did you think this was due to lupus? Are you sure it was a disease activity feature? And without that, I think that's part of the explanation why a number of these trials have come a cropper. Thank you, David. And with that, I have an opinion to ask you about the treat to target perspective of patients
in the strategy that was presented in EULAR, a big survey that asked the patients what they think about it, the T2T strategy, because patients may have other concerns about the disease than we do have. And what do you think about the patient's perspective of T2T? Ron, do you want to start?
Yes, thank you, Raquel. I've of course been very interested in treating to target, but at the EULAR Congress, there was a presentation from Johanna Mucke from Düsseldorf in Germany, but she had been working with colleagues of mine in Amsterdam. And that was exactly the questions. Yes, how do patients really feel about this? And do they like the idea of treating to target? And it turns out that the patient is primarily interested in feeling better, but they accept that if we come up with a good strategy, a good approach, and then it may require also a little bit more active involvement from their part, then they will accept it and they will be happy to participate in that and contribute to that. There's a trade-off. If you set the target very high, it may require more interventions and you may be worried about having to take a lot of medications, getting side effects. So you have to be respectful of the patient's wishes to find the right balance. And in treating to target, we're often discussing what is the right target for each patient. And there were a lot of presentations at the EULAR Congress also about having achieved a remission or achieving low disease activity and trying to find the best way to choose for each individual patient what you want to aim for.
And one of the works that was presented, the pair patient's perspective, I was amazed because patients prefer to have moderate to high risk infections than to lower the steroids and feel fatigue, for example, or more pain. And I can totally understand the position, but it's not what's in our minds when we are treating them. So thoughts, David, about this?
Well, I think there's a couple of issues here. First of all, I'm not sure if it was explained to the patients who participated. When we were talking about, or when the questions were being posed about infection, I assume that what was being got at here was serious infections. I think people are prepared to put up with a little cold, which you might have every 6 months. That's not such a big deal. But I think the aim here was to look at the patients who end up in hospital with serious infections, sometimes life-threatening infections. And it remains the case that if you look at the cause of mortality in lupus, even today, one of the big three causes of death is infection, and that infection is invariably due to concomitant steroids and immunosuppression. The other thing about steroids, I would say, perhaps slightly counter this argument, I have some patients who have a public persona, lawyers, for example, appear in court. And I've had 2 or 3 say to me, just in the last few months, if you like, kind of sticks in my memory, I will not appear in court if I'm on steroids at more than 10 milligrams per day. My face looks puffy. I just won't do it. It's not good for me. It does not. I don't even feel it's good for my clients, one of them said, which is quite an interesting thing for me to hear. So patients, I think, and the reasons why patients take, or very frequently, or sometimes they don't take drugs, is actually something which is very challenging. We did some work on this about 10 years ago with a colleague, Sharon Chambers, looking in great detail about the issue around why patients take or don't adhere to medications. There are many reasons, but it's clearly very important. We know that from the work of colleagues in Paris, which have shown very importantly that hydroxychloroquine, which surely is the simplest and the safest of drugs, and yet Nathalie Chalmot showed very clearly that a lot of patients don't even take hydroxychloroquine properly or indeed at all. So if patients aren't going to take something as simple as hydroxychloroquine, you can imagine that they would be rather resistant to taking more powerful things, including steroids and immunosuppressive drugs.
And there are 2 other things I would like to have you commenting. And one of them that was presented in EULAR was the WIN trial. And I have to say, I'm a little bit discomfortable with it. The WIN trial was about discontinuation maintenance therapy after 2 or 3 years of treatment in lupus nephritis. And it showed that there were more renal relapses and more flares in the discontinuation group. What I would like you to comment is, should we treat the patients for how long would the patients should be in immunosuppressive therapy have or not to have a flare? What's the balance on these, particularly in lupus nephritis and in non-nephritis, non-renal lupus? What do you think about it? David, you're nodding.
Okay, I'll have a go at it, then Ron can come in. So I think this question is vital, actually. It's a very important question. The work of Michel Petri teaches us that about 6 milligrams per day of steroids is a pretty safe dose to take. And if you get your patients into what I call the safe zone, 6 milligrams a day or less, I personally begin to relax quite a bit at that point from the side effect profile of steroids. So my aim with patients, and I'm quite frank with them at the beginning of the disease, that if I can get your steroid down to 6 or less, I think we can both relax quite a bit. And some interesting work was shown actually at the Lupus Academy, I can't remember, it was the last time before in Paris, in which our colleagues there had tried to stop steroids even altogether, even if they got them onto low doses, and no doubt that there were more flares in those patients. So for me, once I get them down to 5 milligrams per day, I don't push too hard to get them off altogether until I'm really sure. Now, Ron and I have had this discussion with others in the Doris group about the importance of serologies. I'm always worried about, sorry, let me rephrase it. I'm more worried at the patient who is in clinical remission, but with high DNA binding and low C3, than I am about the patient who is in clinical remission with a normal DNA binding and a normal C3. And I'm less inclined to stop the patients who are still what I would call serologically active to stop their medication. I like to, perhaps I'm being slightly fanciful here, but I like to think of a low steroid as helping those patients keep away from the evil lupine spirits, as I like to think of them. So I think for me, renal lupus, invariably, I tend to keep the patients on immunosuppression and steroids for rather longer, and that may be 3 to 5 years. With patients who have just a little bit of joint disease, a little bit of joint pain, I've got them into remission. I've got, after, say, a year or 18 months, I've got them on to 5 milligrams per day and a bit of hydroxychloroquine. The DNA binding normalizes, the C3 normalizes. I would be less concerned about trying to get those patients off altogether. I don't rush the renal patients off treatment.
Okay. Do you share it, Ron, or do you have other points to add it?
I think those are a lot of good points, and I agree mostly. But let's face it, the WIN trial was an important trial. It had to be done. But it basically showed that it's not so easy to stop treatment, and that there are risks associated with stopping treatment, which is not what you would like to find out, and it's not what the patient wants to hear, but this is the truth. Now, it ends up being a little bit of a art of medicine. There's the science of medicine and the art of medicine, because in the patient encounter, you weigh all the different aspects, the difficulties that the patient may be experiencing with the medications, the long-term risk with the medications, the long-term risk with the lupus, the likelihoods, and it becomes a complex weighing. And David, you're absolutely right. You can use biomarkers to try to help you in that decision. But in the end, it's very personal. However, I do want to point out that at the EULAR Congress, there was another presentation that's relevant to this, but it was done in a very, very large clinical trial in rheumatoid arthritis led by Maarten Boers, which was the trial called Gloria, where patients were given 5 milligrams of prednisone or a placebo. And this was actually one of the largest and one of the few placebo-controlled trials of corticosteroids. Now, it was RA, it wasn't lupus, but the conclusion was that it helps a little bit, which is what we expected, but it also hurts a little bit because the frequency of infections was a little bit higher and there were some other side effects. So the balance is there. Even at a lower dosage, 5 milligrams, there is still a trade-off. And so the question of whether you can completely accept it, whether you can partially accept it and partially not, it becomes a gradual scale. And I would say that my hope is that 10 years from now, we won't really be having this discussion because we have so many other and better therapies.
David and Ron, thank you so much for sharing your insights. Developments in lupus are certainly moving fast and providing interesting results, which I hope will have a positive effect on our patients with lupus. particularly excited about announcing another first edition, namely that we are introducing our first Congress report on SLE data presented at EULAR, which is available in our library. You can check the show notes for this link. We will be writing these reports for the 13th European Lupus meeting as well as ACR, so be on the lookout for those as well. Our next podcast episode, called Cases from the Clinic, will be released on October 31st, when we will discuss unusual and challenging cases and offer insights into possible treatment. This promises to be a most interesting podcast. Last but not least, we remind you to save the date for our next annual meeting, which will be held in Barcelona from 8 to 10 September 2023. And with this, we thank you so much for listening. If you enjoyed this podcast, please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. In the meantime, you can always visit our website, lupus-academy.org, for more information on episodes, Congress report, and all our other educational activities and resources.